Morning everyone, thanks for joining us today on the third day of the NHS Providers Conference. My name's Bevan and I'm Head of Health and Social Care at BJSS, and we're here this morning to talk to you about how we are planning on co-creating the elective care recovery. Next slide please. So I'm here with my colleague Lee Crossley, who's one of our chief engineers, who's going to give an introduction to himself in a second, but I'm Head of Health and Social Care at BJSS. I've spent 15 years in health and social care, both as a clinician, as an ex-Deputy Director of Finance and Performance, and later as a technology leader. And we're talking today about the elective care backlog. In my time in the NHS, I've delivered clinics, I've templated them much in my spare time as well, and I've also negotiated quite a lot of funding around it. So very familiar with elective care in the NHS. Lee, do you want to give an introduction to yourself?
Yeah, sure. Morning, everyone. Thank you, Lauren. Yeah, great to be here this morning. Lauren's invited me along because I'm a chief engineer at BJSS. So effectively, my role is to make sure that we deliver the right solutions for customers that are appropriate. But also, I've got a bit of a background in IoT, and also earlier this year, I've been involved in some appointment rebooking systems. Not in the NHS, but obviously there's a bit of relevance there to what we're going to be talking about today.
Thanks, Lee. Next slide, please. So at BJSS, we do quite a lot around service design and user experience, and we've worked quite a lot with the e-referral service. So we build and run that for NHS Digital, and have worked on things like the NHS app, so citizen-facing technologies. So through both of those programs, we understand quite a bit about the elective care pathway, what that means for patients, healthcare professionals, and also for people who are in the queue, which is what we're here to talk about today, really. Please do ask us lots of questions. There's the question function, which hopefully over the last couple of days you'll have come familiar with, but do ask us lots of questions. There's plenty of time for Q&A at the end of it, so please would encourage you to ask us difficult things. So I don't expect people to be able to read this, but it's a demonstration around how complicated we understand the elective care process to be, both from a GP referral perspective, the identification of need, all the way through the triage process into queuing, appointment, and then managing those appointments once they're kind of in flight, which obviously providers have had to do a huge amount of work on cancelling appointments, retemplating, understanding what can be done from a face-to-face and non-face-to-face perspective over COVID, and actually, as we go back into a second wave, or however many waves, we understand that that's going to put a huge amount of pressure on providers, on their staff, and on their systems and processes. Next slide, please. So we've spent quite a bit of time thinking about how technology might be able to help with that. We don't think it can solve all of the problems, but we wanted to spend some time thinking about how technology might be able to help with some of these issues. So Lee, over to you, just to think about, from your perspective, from service design, how do you think a service design approach might help with some of these issues?
So, I mean, this is a little bit of a sort of generic statement I'm going to make, that engineers, we like to solve problems, and we like to solve the right problems, but knowing what the problem is to solve and whether we're actually hitting the user needs is a difficult thing to do, especially without any sort of research or service design. So what we tend to do is we do a bit of what we call a discovery, or a bit of user research around what that service should look like, what the pain points of the individuals involved in it are, and get them on board and understand exactly how we can make their lives easier and improve the service. If you chat to somebody within the NHS that is a professional that needs some kind of help or guidance, or a service design, and you say, right, okay, what is it that you need? They can't really articulate that, mainly because they don't know the art of the possible, but also because they're they kind of are in a place where they don't have all of the information to hand. So what we do is we could do things like lived in experience, sit down with people, walk them through what their day-to-day looks like, and then facilitate that with technology. In my career, I get a lot of what I call solution statements from customers, which is, we need this, we need X, we need product Y, we need product Z, and it needs to look like this, rather than saying, right, we've got a problem with our users, or we've got a problem with this. how can we solve it, and then look at the different options to solve it. That's a very kind of different mindset. So without that kind of user research and service design, you're not going to build the right thing, or you're not going to buy the right product. Off-the-shelf products are actually, they rarely excel at being fit for purpose. So if you do buy off-the-shelf products, you need to make sure that they are the right thing. You know, you've got the right security wraps around it, you've got the right privacy, the data stored in the right place, and that these systems are linked together. It's not just a siloed system which isn't fit for purpose.
A great point, Lee, around kind of linking it all together. And I think that the thing around service design, and the reason we take a service design approach, especially for something like elective care, it's lots of different people have got lots of different perspectives. So there'll be a huge amount for the, you know, the people that are running the PTLs, so the waiting list administrators, the service managers, the clinicians, the patients will all have different points of view, and will all have different pain points in terms of what is frustrating them about the process and the way that it works at the moment. And I think that there is always an art of negotiation in this, and in terms of it, by fixing a problem for one person, sometimes it can make a problem for somebody else. I think about that when I think about how sort of PTLs get managed, and I used to sit in quite a lot of the sort of weekly RTT meetings where people would talk about prioritised backlog and patient mapping. And by moving patients around in the system, sometimes it would create unexpected issues for people in other parts of the trust. So in diagnostics, or in RAD or pathology, then there is always that art of unintended consequences. And again, unless you think about the whole process from end to end, there is always that risk of unintended consequences. And there's a huge range of people that are affected by this as well. So there'll be some people who are less digitally able and able to engage in it. And I think that's one of the things we're really conscious about. Although we're a digital and a tech firm, we don't, you know, live in a world where we think that everybody's got smartphones or everybody wants to engage through digital channels. We are painfully aware that people don't want to engage in that, particularly sometimes when it comes to their healthcare. So again, just thinking about how we might be sensitive to those needs and think about sort of omni-channel. I remember being in a conversation in a panel in February this year, which seems like a long time ago, with Tara Donnelly from NHS, and she mentioned that NHS trusts, I think, spend £2 billion on second-class postage stamps through outpatient letters, and that was absolutely staggering. I think that's the biggest kind of driver of Royal Mail postage services. So I am also aware that lots of people are getting communications which are not necessarily fit for purpose at the moment for them either, because through COVID especially, the postal service has been under significant demand. So a lot of those either clinic reschedules or cancellation letters may also have not reached their intended recipient in a timely way either. Just moving on then, Lee, to the IoT, so Internet of Things questions. I know this is one of the things that you are especially keen on. Really interested to hear your thoughts about how IoT might be able to help, in particular around things like understanding how patients and staff are socially distancing in hospitals as well.
Yeah. I do love IoT. Just one last point on the service design that I wanted to cover off was it's not just always about happy path. I mean, these, you know, edge cases tend to crop up 9 times out of 10. So it's about thinking about the user experience, and when they do deviate from your, you know, intended pathway, what then happens with them? Like, how do you pick them up, and how do you get them back on track? So it is quite a complicated thing to design. And moving swiftly onto IoT, there are ways that IoT can help with that. So once you've done your service design, you've understood exactly what your intended kind of target operating model, whatever it might be, looks like. There are devices out there that can help with that. You might think that IoT in this setting might mean, you know, people at home with wearables, or you know, self-surgery, iPads in mouths while they're trying to, you know, take temperatures and measurements and all that kind of stuff. I actually think that Internet of Things has a setting not in the home, but actually in the in A&E departments and other places where patient flow is important to measure. At the moment, I'm not quite sure whether, you know, trusts can accurately say whether they adhere to things like social distancing. So there are a number of companies that kind of spun up very early days in sort of March and April, which had, sort of tags that you could wear around your wrist, around your neck, that would sort of beep when you came within 2 meters of somebody. We're actually working with a trust at the moment to develop something where we're tracking the entire patient journey through the departments. So it's not just, oh, they're in this room for this long. It's how long did they take to get to the next room? How many other people were in the room? Which side of the room were they on? And using that data, because at the minute, we don't have it. We don't know whether we can increase the amount of capacity or have to decrease it. So it's about making sure that we have the data that backs up some of those decisions so you can make informed decisions. I actually heard a phrase the other day, which is, if data is the new oil, algorithms are the new refineries. And I really like that. I think that, we can't do anything without that oil. So let's refine it and make sure it's fit for purpose, which might lead us on to the next point, but I'll hand back over to you, Lauren.
Yeah, absolutely does. It's almost like we planned it, Ailey. I think, so the IoT thing is a really interesting thing, because I think there's a way of doing it with sort of privacy in mind. So I think that's one of the things that we're kind of super keen on, is around not making this into some sort of surveillance point, but actually outpatients from a PAS system perspective, it's really difficult sometimes to understand how long people are waiting and how long they're kind of waiting for appointments. It's not obviously like an A&E thing where you've got the timestamp and you can understand the time duration around people going in through the different processes, through triage, through medical review, to point of discharge or decision to admit. So from an outpatient's perspective, I think that would be really useful. Certainly when I was working in the NHS, I would have found that data really good to understand how, linking to complaints and PALs and things like that, to understand if people are feeling frustrated because they've been made to wait ages for an appointment and then have to go and get, say, a blood test or get an x-ray taken or things like that. And I think being able to understand that flow through the hospital and understand how patients are moving through and how their journeys are from their appointment, I think would be really useful. So very keen to kind of explore more on that. From a data perspective, so we've talked about linking some of these things together already from an IoT perspective, and also from a service design perspective. But I'm going to keep you aware, we've done a lot of capacity and planning work in BJSS, and I've done quite a bit in my past as well. And one of the things that has struck me is that would be really hard to do in this scenario. It's really hard to do because usually you would use your previous 3 years worth of data to be able to plan and forecast into the future. And obviously that can't hold water anymore because we're not in the same circumstances that the last 3 years have been in. And therefore, all of that data and historical trending that you would use in order to understand your capacity and demand is kind of worthless now. And that's, again, really depressing as someone that's spent a lot of time, a lot of late nights refining and endlessly tweaking capacity and demand models. But I think what we're seeing and what we're using at the moment is around sort of AI machine learning to see if we can get early triggers to understand actually how capacity and demand is changing shape, and using that to have something which learns what those behaviours are, in particular as areas go into local lockdown as well, being able to plan and forecast with a bit more accuracy, or understanding the level of accuracy that you're working at, I think is going to be particularly important. And I'm aware that obviously the contracting rules have changed to block as well. So from a financial perspective, being able to get a grip on actually how much your service is going to cost to run, now that you've got a fixed income allocated to it, is going to become even more important than it usually is. Lee, have you got any points that you'd want to add to that?
Yeah, I mean, lots of points on data. I really like the bit you mentioned about privacy. Even though I say Internet of Things, I actually make it part of my life's mission to make sure that things don't send data to the internet if they don't need to. So actually, there's a solution that we're working with a trust for to look at the patient flow and the movements. It actually isn't connected to the internet. It's all a local server, so it's classed as IoT, but it's actually not on the internet, which is a great thing. And I think that people should maybe look at what they're doing and where they're storing their data a little bit more. So on the data part, I think data quality is actually one of the key aspects here. If you, let's say, you've had a number of patients which need to have their appointments cancelled, you might not have tracked exactly what the reason for cancellation is, and various other points and metadata around that. So what's critical is to make sure that your sort of data lineage and your decision making is still kept, because if we move into intelligent automation, which we're going to look at next, and AI and other things, unless you have all of that sort of data and understanding as to why past decisions have been made, it becomes difficult to make informed and relevant decisions in the future. So, I mean, let's say, I had an appointment and it's been cancelled, and it was, reason due to COVID. There's a little bit more to it than that. I mean, it could be that it was cancelled because I couldn't get there, or it could be because, I was self-isolating, or various other reasons, and that might actually have an impact on the care that I should receive. So I think that unless you're capturing all of that data and it's stored and visible and available for making decisions, you're going to end up in a position where you're making some of the wrong choices in the future.
It's a really good point, particularly around linking to things like the shielded patient list and other things like that, to understand what category your patients in the backlog are in as well. Because I think it's also then about understanding how to do that clinical triage and prioritisation, because obviously there'll be some people whose conditions who've deteriorated. There's always that spontaneous remission where people actually get better, because our bodies sometimes are wonderful things and sometimes are not. And being able to understand that in a little bit more detail, I think, would probably help from a planning perspective, and understand actually what additional clinics need to be put on. And if somebody is self-isolating, then, or on that shielded patient list, then being able to understand that you probably need to offer them a remote consultation, I think would be really valuable, because I've seen some stories of where patients have been asked to come in to the trust property, so come on site, whereas actually they've been recommended by their GP through the shielded patient list not to do that. And I think it's really hard for patients when they're put into that position to understand what advice they should be following, because both sets of healthcare professionals who are responsible for the care of that individual are giving a differing view. And I think that's really hard to get your head around. So I think there is also something about linking all of those different things to give the patient more clarity about what they should and shouldn't do, and just to increase the patient journey and sort of increase the patient experience in a time where people are really stressed and it is really difficult for people to know what they should do for the best. So moving on then to the final point here around intelligent automation. So this is kind of RPA, intelligent automation, all of those things where you kind of automate different processes. We think that there's a real point here around how to help those people who have had a huge amount of extra work landed in their inbox as a result of COVID. So also really keen to think about how those processes are explored to help manage workload and prevent burnout, because there's an awful lot of people, all of you who are sitting in the audience, I'm sure included, who've been working absolutely, to the floor through COVID, managing all the different messaging and working with your trusts and with your teams. So again, just thinking a bit smarter around how some of those processes can be automated so that staff are doing more around how to engage with less digitally able patients, and thinking about how they're able to I guess, do less of that repetitive processing, because everybody's tired, and I think that's when mistakes are made as well, which is good for nobody really. And I think it's not just about cost saving. Obviously RPA and intelligent automation has always been discussed of in terms of automation, but I think in our experience over the last 6 months, there's a huge part to play for all that additional activity that now is expected to be absorbed into current workload. And just thinking about how some of that might be delivered in a different way, so you can cope more with the bursts that come through when second lockdowns happen, or some of these local lockdown laws come in. It's also just thinking about how you get things kind of teed up in the background, ready to respond as the situation we expect to be fluctuating for depressingly for the foreseeable future. Lee, what's your view on this?
Yeah, I mean, I think there's different kinds of intelligent automation. I think there's that sort of strategic, let's take a view across an organization or a department and look to see where RPA, or so robotic process automation or intelligent automation, can help and assist. it's not a silver bullet. It doesn't solve everything, and you should never walk in wanting to sell a product like an RPA tool. It should be looking at the problem and the user needs, coming back to the service design, and making sure that you're fulfilling those needs. And if RPA or intelligent automation forms part of that, then great. The other part is that sort of tactical. We need to do something quickly. Something unexpected has happened. So I was actually involved in a project earlier this year where we had 40,000 emails come through for a government department of people, key workers, requesting an appointment for something. And problem was sifting through those sort of 40,000 emails and figuring out whether the key workers were eligible and actually making them the appointment was estimated to take about 3 months, and that 40,000 emails kind of appeared in a week. So we actually spent 3 weeks from inception to release and clearing the backlog of coming up with a solution where RPA was part of it, where we got the individuals to fill in a more detailed form with more structured data. And we did all of that rebooking process. And yeah, we cleared it in those sort of 10 days. I think it was 3 weeks. And the system was then available to support for the rest of the duration, and will probably be used again, to be honest. So I think there's different kinds of intelligent automation, and it isn't a silver bullet. And I think a lot of people kind of think that RPA is the solution and the answer to all of their overloaded staffing problems. I don't think that is the case. I think it takes a little bit of careful consideration to make sure it's the right thing that's fit for purpose. Another sort of common misuse is we're talking about siloed systems before, and off-the-shelf systems. One way to integrate them together is to use things like RPA to move data between one and the other. That can be a good use case sometimes if you've got stable systems underneath and it's a sort of temporary solution. But often these things do have APIs, and there are ways of doing it and doing a bit of data quality checking and things around it. So even though it's great, it's not the solution to everything.
If we can just move on to the final slide around questions. So we've got a couple of questions in. Please do ask us lots of questions. There's two which I think are paired. So one from Nikki Lucy around information flows on capturing data is a real issue. So at the moment, there's a view around the emphasis being placed on acute providers to find the information rather than the information kind of being flowed into them. So again, when someone, I guess, presents at secondary care, there's an expectation that they will be able to, suck all the relevant information around that patient and other services that they might be using in around, and asking us a question around whether or not there's any work that we've done around automated information flows in, not just across primary care, but across independent sectors, which links to another question that we've got around imaging. So one of the ways that the private sector is being, or the independent sector is being used from a recovery perspective is to help with some of that diagnostic imaging burden. So that in itself will also create a different dynamic in terms of being able to needing to share sort of RIS-PACS imaging back into secondary care. And that's going to become problematic. I remember getting a CD-ROM with my hip MRI on last year, which can't be good. Like, I can't be in the interoperability between the two systems. So there does have to be a better way for it. So Lee, from your perspective, in terms of automated information flows, can you give some examples where we've done some work around that, and then I'll pick up the other point?
Yeah, so I'm kind of thinking I'm going to take this slightly out of healthcare, if that's all right. So in operations departments, generally what we want to do is make sure that all of the information is available to the systems engineers, the operational analysts, whoever it might be. So if you've got an alert or an issue that comes through, you want all of the data that's associated with that, and past actions, past performance, what other people have potentially done, to make sure that you're effective and doing an informed, making an informed decision about what you're what the thing is. So I think that applies here. It's about making sure that you have all of the data at your fingertips to make that decision, and that could be from different systems, and yeah, it's a tricky thing to get right. Which comes back to the kind of service design piece that we're talking about. if you say to an operational analyst, what data do you need? They'll say, maybe, you know, I need A, I need B. They won't know that C is possible, and they'll have forgotten about D and assume that they get an E anyway. So sitting down with them and actually looking through it and seeing where the gaps are and looking at their pain points is super key.
Yeah, I think on the RIS PACS imaging, I think that's something that we know is going to be a more standard use case, because we know, you know, if there is a plan to outsource some of that to the private sector, you'll end up with a more disjointed patient pathway, with patients having an initial outpatient consult, being sent off for a package diagnostic test somewhere else, and then potentially coming back to Trust A for their you know, outpatient appointment to discuss the treatment plan once the diagnostics have been, once the workup's been done. So I think that from that perspective, from a RIS PACS perspective, there's two issues there which need to be unpacked. One is to do with the size of the images, which is part of the issue, is to do with the volume and veracity of the data which is flowing. And the second thing is that it needs to be done probably on a national network scale. So there's two ways of going around it. One is to think about it in terms of a national system where you would use a central repository. So all the images would be sitting in there, and then trusts would grab from that central repository as and when they needed to get that outpatient consult. So you don't necessarily have to have that patient's treatment pathway planned out to understand that it goes A to B. Everybody goes from A to pool X, and then all the trusts would then grab from that pool. Or the second way is to understand if the plan is to have ISTCs or similar paired with trust, that then becomes a more linear relationship where you've got a one-to-one, and actually you know that all of your trust's patients are going to be hived off to a specific diagnostic treatment centre. That becomes easier to engage with and engineer a solution if you think it's just going to be a one-to-one relationship. But I think that, again, going back to the issue around data security and privacy, I've seen it done just via emails, and that obviously isn't great from an IG perspective, and it's not a secure way of going outside of the NHS to be able to get some of that information. So I'd be loath ever to recommend that, but I'm aware that it's operational common practice. But I do think that there definitely is a way of doing it. From our experience of having built ERS as well, then we've done that interoperability between the PAS systems and also between the sort of trust to trust as well. So it's definitely doable. It's definitely something that needs to be thought of, probably on a national scale, given the plans for backlog clearance. And it is technically possible, but please don't rely on email. I think we've got 5 minutes left, so I'm just going to take one more question. So that is just around what IoT products do you think would be deployed by some NHS providers to help with prioritising backlogs? And given Lee is Mr. IoT, I'm going to pass that one over to him.
I do like an IoT question. I think you make a really good point as well about security and privacy. Like, they still need to be paramount, even if we're doing tactical solutions, you know, that are implemented quickly. They still need to be secure, robust, and if you're using off-the-shelf products, they need to go through the correct due diligence to make sure that, yeah, exactly the IG that you were talking about is met. IoT, yes. Obviously, I want IoT products everywhere. They don't necessarily need to be connected to the internet, but one thing that we've been looking at is Bluetooth beacons. So when you register in a facility, getting either lanyard or wristband with a Bluetooth tag that's associated to an ID. As you move through different rooms, different consultation areas, hallways, it measures your effectively your journey and your path, and also measures everybody else, and surfacing that data to run analysis on it to see whether there are certain bottlenecks or things that can be improved in that process. But actually, the really interesting part is when they come to hand that wristband back or that lanyard back, is asking them about their experience and finding out from them, what they perceived to be good or bad about their visit or any kind of waiting times, and marrying that up with the data and other data sources to figure out how you can improve that experience.
Fab. We are just almost down to time, so just wanted to say thanks very much for your time this morning. Hopefully you found it useful. BJSS is we were exhibiting, so come and see the stand, ask us any questions, and if you've got any additional questions that this has brought up, then please do drop us a line. So we're on the stand for the rest of the day. So I hope you have a great sort of last day of the conference. Thanks ever much for your time and attention this morning, and yeah, thanks again.
Thank you.